First, we will hear from Dr. Vangelis Metsis, who is an associate professor at the Department of Computer Science at Texas State University, as well as a faculty fellow in our Translational Health Research Center at the university. Dr. Metsis's research interests center on machine learning and computer vision with applications in smart health, pervasive computing, effective computing, and human augmented reality and virtual reality interactions. I'll hand the conversation over to Dr. Metsis to get us started today.
All right, thank you, Lauren and Shelby, for the introductions. Let me share my slides. And okay, hi everyone. So I was gonna say a few things about myself, but I think we already established the introduction, so I'm gonna skip that. Just want to acknowledge my lab, the Intelligence, Multimodal, and Computing and Sensing Laboratory at Texas State University, and also thank the THRC, the Translational Health Research Center, for sponsoring this work. As Lauren mentioned, my research is in machine learning, AI, with applications to understanding complex human activities and also health. So today's talk is part of a broader ACOS connection series of sessions that maybe you have attended. And today we will focus on AI and mental health. That's an intersection that is very important these days. And we want to talk about opportunities enabled by AI, challenges, and strategies. So let's get to it without further ado. So just to set the table, let me just mention a little bit about what AI is. So you probably already have heard this term thousands of times, but it's basically computer systems being able to perform tasks that require human intelligence, either being learning, problem solving, understanding human language, and so on. So it used to be previous iterations of AI. Usually humans had to explicitly define a set of rules that AI systems had to follow. But more recently, we have this branch of AI that we call machine learning that has been booming. And the difference between traditional AI and more recent development is that machine learning learns directly from data. So in other words, humans specify algorithms about how to learn that information. And then machines learn from data directly. So there's no control of what machines will learn, just how, what is the learning process. Now, we can partially control what machines learn based on what data we use. So it's important to have quality of data that is good. And the even more recent development in the area of machine learning and AI is large language models. You might have heard this term. These are big models that have been trained on massive amounts of text data, but more recently we have multimodal data that are trained on images as well, videos, and so on. So you might have heard some examples like GPT-4, Gemini, Claude. All these models have the ability to understand questions in natural language and prompts, answer questions, generate human-like responses, and also, summarize, translate big text documents, generate schedules, all this fancy stuff that you might have had opportunity to see. But with respect to the mental health aspect of it, you might have seen chatbots, virtual assistants that are starting to pop up that are supposed to help in this direction. So on the next slide, I have a couple of examples of those, Wiza and Wobot that you see the logos here of those are essentially applications, phone applications where you can send messages and receive responses, and you can get emotional support, mood tracking. And the difference between those applications and the general large language models is that those are kind of tailored to mental health. They probably follow some protocols like cognitive behavior therapies to support users. So they have been adapted essentially from general AI capabilities to emotional support. So some of the potential benefits of this kind of applications is that they increase accessibility, they can support anonymity, and they can provide immediate support to users that maybe otherwise they wouldn't have through the traditional clinician support. Other similar platforms that exist out there are cases like Coco. This is not just an app, but a support group. It's a platform where peers can help other people when they struggle with. So they have been deployed to Discord, Slack, and this kind of applications where there is a direct human-to-human interaction. But recently, they have also started introducing AI as part of the support, initially for organizing and moderating discussions. But later, as we will see with Coco, there is a case where they actually started using AI for responding to human queries. And that's part of the controversy, which we will discuss a little later. So all these tools can enable, early detection. They can do proactive intervention before certain stages of mental health rise, provide warning signs, and so on. So great. We're gonna talk about possible opportunities that AIs can enable. And then we're going to talk about the challenges. But let's first start with the opportunities, which is what are the exciting directions that we could take by using these AIs? Well, to start with, AI can bridge gaps and barriers in mental health. For example, it can help people in remote rural areas that maybe don't have access to clinicians. Or it could overcome mobility issues. People cannot get to the clinic, or maybe they have difficulty scheduling, that kind of stuff. And they can provide support 24/7, like an initial support, at least when somebody is having an issue, a breakdown or whatever, they can immediately get support and not wait for the next available appointment. And even more important, they could potentially reduce stigma. A lot of people maybe are a little bit hesitant to expressing their struggles with mental health and reaching out to therapists. But with these kind of applications, many of these AI assistants could promise anonymity, and they can provide that so anybody can talk to them and nobody else has to know about it. Another opportunity is personalized treatment. So as you know, traditional healthcare follows mostly the one-size-fits-all approach, where people maybe will fill some questionnaires, and based on that, they will be evaluated and they will be bucketed in some kind of treatment, some medication that might work for some people, might not work for some other people, might make things worse. Well, with AI, we could create personalized treatments that dynamically adjust to each person as they improve or they get worse. AI can identify specific patterns by monitoring, let's say, our physiological biosignals, our journals, find what triggers our anxieties, our emotions, and possibly provide advice directly, or provide some data to the therapists to use, and then personalized treatments for users. Another opportunity is scalability and predictive insights. So this has to do with the clinician side. So therapists have a ton of cases to handle. They have to see so many patients, and on top of that, they have to handle all the scheduling issues and all these things. So AI could potentially automate some of that and provide summaries and insights. For example, between visits, where the AI could collect data and provide a summary to the therapist for the next visit. So essentially, the goal here is not to replace therapists, but to augment and assist their work. And on top of that, AI could help in other directions. For example, people these days use social media a lot. They can post something there. So AI could possibly detect early signs of possible risk of suicide or relapse if they had the condition and they're currently under treatment, and so on. So all these are opportunities that you can imagine. But now let's talk about challenges, right? Because the adoption of AI depends on overcoming these challenges. So the first challenge that maybe is the most important is ethical and privacy concerns. Current clinical practices have established protocols like HIPAA, anonymity, and all that. But when we share our data with AIs and companies, how is this data being used? This is these are private data. Mental health is one of the most personal things that we don't want to share with the outside world, right? Then there's algorithmic bias. So these AIs are trained on data that maybe contain some biases already. Maybe they are tailored towards particular dominant groups, and they don't consider the specialties of certain minorities. So all these are problems that AI could face. Plus, the AIs have some technical challenges these days, which we'll see in future slides. Another important aspect is informed consent, right? So we want to let users know how their data are being used. But when they have to deal with such complex AI systems, users don't understand exactly how, like there might be a description there, but not everybody is a data scientist, right? So even they tell you how this data is going to be used, not everybody can understand exactly. So they maybe consent to something that they don't fully understand, and that's a problem. Then we go to technical hurdles, which is inherent problems with AI and machine learning applications in general, not just in mental health. But one of it is accuracy. How accurate are these systems in detecting mental health when they raise a flag? Is it true or not? So I would say this is a problem that maybe is not as important, because we do have metrics currently of evaluating how accurate AI is, and maybe that's something that can be solved in the long term with quantitative measures. But then the problem of black box remains, right? So yes, AI can tell us how confident it is in its prediction maybe, but why it came to a conclusion, that also matters. So experts, doctors, therapists, and so on need to have some kind of way of knowing how did AI come to this conclusion, not just the conclusion itself. Our traditional clinical practices usually do that. We have a set of steps that lead to conclusions, right? And finally, current clinics have established workflows that they follow. And can we just throw in technology without disrupting all that? How can we integrate technology in a way that is seamless, right? One of the last barriers that I want to mention, or challenges, is social and cultural barriers. So I mentioned it before, there's cultural sensitivity. Many of these models maybe lack relevance for appropriate or for diverse populations. They have been trained and maybe in particular languages or particular cultures that are more dominant. And by nature, AI tends to favor outcomes that are more statistically probable and groups that are more statistically prevalent. So that could affect minorities. Okay. There's also clinician skepticism, right? So on the side of the clinician, maybe some of them are even worried about their future role and their jobs. But more, importantly, what are the liabilities that they might be facing if an AI makes a mistake and then they get sued about that, right? Or what happens to the therapeutic relationship with the patients, the one-to-one kind of communication, when patients mainly communicate through AI instead of directly through them. There's also worries about de-skilling. If you over-rely on AIs to do a lot of the important tasks, maybe they will start losing some of these skills. And then on the patient side, there's also skepticism about how these data are being used. Nobody wants to be judged by an AI, right? We feel this comfort in relationship with our doctors, so maybe the same thing doesn't apply when you're judged by a machine, right? So that's another problem there that some people could be worrying about. And eventually data exploitations. What if there are data leaks, and so on. All right, so to conclude with the challenges, trust is an important factor here that is foundation for everything. Like if we think that these opportunities are important and we want to adopt AI to solve some of our current problems, we need to solve the problem of trust. And this problem can be solved by overcoming some of these challenges, of course, and is the foundation for adoption, engagement, ethical use, and clinical validity of this kind of applications. So on both sides, both the patient and the clinicians, but also other stakeholders that could be part of it. So in the next few minutes that we have left, I want to give a couple of examples of where and how to build this trust and where this trust could erode, and then talk about some strategies. So transparency is an important dimension that can help build trust. I mentioned this company Coco earlier. So this started as a peer-to-peer support where certain users would answer questions from other people and give them emotional support. But at some point at the end of 2022, when ChatGPT appeared, they decided to test GPT-3 in drafting messages to patients or users that contacted them instead of humans writing those messages. And humans would still review those messages and provide kind of make sure that they are okay before they send them to users. But they were initially written by the AI, right? Later, a couple of months later, the CEO of the company went online on Twitter and kind of boasted about how drafting messages with AI, users liked those messages better than the messages that were drafted by humans. And he thought, that's a great thing. But there was a lot of backlash about that because users were not informed about it and did not consent to getting responses written by the AI, right? So this is an instance where transparency failure eroded trust and caused problems for that company. I have another example here where transparency actually worked. It was about an actigraphy watch that was used to monitor sleep quality, daily activity, heart variability rate, and then that was used to predict mood disorders, anxiety, and so on. And in this case, this was a paper published. Actually, things worked out well and users were happy with the outcomes because mostly they understood, they could relate with how their data, sleep quality and so on could affect their health. And there was transparency about what data was used, how they were used, and how it links directly to their health outcomes. So the takeaway here is that explainable inputs and outputs and processes foster trust. So we should keep that in mind. So next, I want to give a few strategies that maybe stakeholders should adopt to build trust. The first one is explainability. So we want to show when AI makes a decision, sorry, why it came to that conclusion. We talked about that earlier as well. The next one is interdisciplinary collaborations. There is not a single group. AI scientists or engineers cannot solve this problem by themselves. We need to involve mental health professionals, ethicists, even patient advocates, so that they can talk about problems that patients face, and policymakers. And this has to be done from the start of the design of the systems. Currently, we have the general large language models, and then maybe we adapt them a little bit for this kind of applications. But this is not the best approach for developing systems that are robust and reliable for this particular sensitive applications. And the ECHO principle here of collaborative approach and discussion certainly applies, and I'm glad we're having these conversations. Strategy number 3 is developing ethical frameworks and governance around this issue. So there need to be clear guidelines and standards and even regulations, maybe even laws that kind of govern this, how these data are being used. What happens when something goes wrong, who is accountable, maybe mitigating biases, establishing rigorous validation protocols before these systems are deployed in real life. And ensuring, of course, that clinicians remain in control and have the final say in any therapy that might be administered to patients. And the last strategy for today, coming close to conclusion, is ethical data practices and informed consent that is understandable to the user. So first of all, users should have control over their data. If a user decides that a particular stakeholder should not have access to their data anymore, they should be able to have those data deleted at any time. And we also need to be mindful about what kind of data is being collected from wearables, text, and so on, and how they are being used. This should be all transparent. So looking ahead, what is the future of AI and large language models? So there's already, emerging research in areas such as digital phenotyping, where large language models, by modeling your history of interactions, your sensor data, and so on, can build a profile that can be used for helping you. It can also be misused as well. So it's sensitive area. Real-time adaptation of interventions, even vocal and facial biomarkers. Systems now can monitor your face, your voice. It can detect if you are currently facing anxiety symptom and so on. But we should be careful again of over-reliance on these systems. Sometimes when we see that something kind of works, we just over-rely on it, and we tend to not be as rigorous anymore. So we need to be careful about that. So a final recommendation before I conclude is that collaboration and community is important here, an important path forward. We must involve clinicians, patients, ethicists, all the stakeholders when developing these systems and before we can deploy them to real-world applications. And this kind of style of eco-community model, which leverages networks, is, I think, a way to go, and I'm glad it exists. So last slide, I'd like to thank everyone for attending this talk and for your attention. And I have here 3 questions that I'd like you to think for afterwards when we have the discussion session, I'm sorry. So is AI in mental health a top concern or a key opportunity? How do you see it at this stage? Also, if you are a stakeholder, what is one practical step for making you trust AI in your setting? And finally, what's the most crucial safeguard of ethical data use? So thank you all. So next, Dr. Makady will give us the case study or a particular application. And after that, we will have the discussion session. So I'm going to stop sharing right here and move on to the next session.
Perfect. Thank you, Dr. Metsis, for sharing this kind of overview of the field and the state of science, and these conclusions with us, I think, are really fruitful for our discussion in a moment. Before we get to the group portion, as Dr. Metsis mentioned, we'll hear from Dr. Heidi Makady, who is an assistant professor in the School of Journalism and Mass Communication at Texas State University. Dr. Makady's research centers on human-AI interaction and human-machine communication, examining how audience algorithmic awareness and understanding of AI recommendation systems influence our attitudes towards AI-enabled technologies, including wearables. So now I will turn the conversation over to Dr. Makady to share more about her work with us.
Thank you so much, Lauren, for the introduction. I will not introduce myself further since that has been done. But before we go ahead and speak about this conversation, I'd like us to know that where are we now in terms of the emerging clinical studies? Well, there has been promising applications in chronic disease management overall in physical health. But when it comes to mental health, the conversation is a little bit different. There has been promising results in different avenues: panic attack prevention, depression treatment, evaluating or management of OCD or detecting mental disorders. Now, this has been being said. One important information here is that what the clinical studies have been telling us is why our users or patients or providers are feeling that this is something important. Most of them are basically, if you have a glance or a quick look, it's mainly about self-awareness or how they can manage anxiety or the triggers or what actually looks at them that they can do, mainly even patients or clinicians. If you look here at the control of their symptoms too, so they have been helpful in that avenue. But are we really yet midway or in full swing adopting these technologies? Well, we're not yet fully there in mental health protocols. And that's what the clinical studies over the past 7 years have been telling us. Now, the question is, and I know my peer, Dr. Metsis, have been telling you about the main challenges that has been happening in adopting those technologies. And actually, the meta-analyses of those studies have told us that both, if you have a quick glance, patients and clinicians are giving us some privacy, data security, building trust, And those are actually reinforcing what the data that Dr. Metsis have been talking to us. So this is actually something that even clinical studies have been concerned about. Now, moving forward to specific case studies, I would like for you to know, as providers and data handlers for my audience today, that actually that area has been looked at since 2018 or 2017, so that is not new at all. And one of the case studies, clinical studies that have been looked at was the use of Fitbit in post-traumatic stress disorder among veterans. And as you can see as well, one of those positive avenues was the support for social interactions. And I want you to observe the positive side here. They also said lack of clarity and lack of meaning. So it's not positive all the way and it's not negative all the way. The second case study that has been done was using Fitbit for depression. And that was actually an intervention that was found helpful in complementing behavioral activation therapy, tracking what patients have been doing. And it has similarly said what the clinical studies have been showing us, mainly self-awareness, peer motivation, and goal-setting opportunities. But we still do have problems with inconvenience, inaccuracies, and disinterest. Now, I know that I'm been here trying to help us understand from a human communication perspective, how do we get audiences or get consumers or clients trust? We do look in the human-machine communication side at the technological aspects and the psychological aspects. How do we get to trust specifically? We do look at the perceived ease of use and perceived usefulness, because those are drivers to trust and eventually intention to use. So to explain to you how does that happen in a model, if you look at all the negative sides in terms of trust, these are directing into perceived ease of use or even perceived usefulness, which eventually lead to trust. But one underlooked area is something called anthropomorphism, and that is something that I have been looking at in the past few years. Essentially, I know it's a very hard word, conglomerate word, but anthropomorphism is the tendency to assign human-like features to non-human objects. I know by default, us as human can look into buildings or things by design and think of them as having human features or motivations or technicalities, but looking back at how we can use anthropomorphism into trust, I think one driver for that is when we looked at the clinical studies, one very recent study have been showing that it has been useful for clients or patients when the more they feel comfortable communicating with it, the more likely they would feel it of this smart wearable as a companion or sense of connectedness. Now, it was more important for clients, of course, than patients, more than providers. And we can start thinking of how human likeness can help us in that avenue, especially in having them as co-agency. I know Dr. Metsis have talked to you about explainability, and I'm not going to talk through that. My main focus is how we can use AI as a companion and how human likeness and those wearables can help, especially with the higher rates of less social interaction, financial constraints that has been happening in the chronic loneliness rates that we have been seeing. Now, one study that I have been looking at is I was intrigued during the pandemic to see what are the drivers for someone to anthropomorphize or have a human likeness in something, because not everyone will do this. And mainly what the study has found was the more likely someone would have a need for affect or to have a sense of they want to feel emotions, desire for social connectedness, or they have uncertainty avoidance, the more likely they will assign human likeness to those devices, especially if someone has chronic loneliness. And the main drivers that was interesting in that avenue was that this was more among females and users of lower income, and those who were trying to dodge uncertainty avoidance. Also, users who were higher in age were more likely to do that as well, anthropomorphize or see it as having more agency over them. Now, to wrap up, some practical applications. How does that even make sense in our practice? One avenue that we can look at is if we can trust AI wearables and smartwatches in our lives that could be guiding therapists or clinicians. We cannot have a clinician 24/7 available to clients or patients, but those smartwatches can help us in between sessions or in between their visits to give them guided prompts to manage their symptoms and also give them a sense of companionship, which essentially could lead to trust while they're using it. Now, as a final thought, I want to draw our attention that even though the most human-like features we have, ease of use is something important, but if we don't have clear data sets, we will not be able to achieve that. And one thing that I always like to tell all practitioners in this area is that specifically in clinical settings, smart wearables cannot substitute therapeutic relationships or a therapeutic alliance, but it can only boost it forward if we can build trust in those settings. Thank you so much for listening into those little insights that I had today.